Welcome to Behind the ABA Talk podcast, where we have heart to heart conversations with ABA experts, thought leaders, and changemakers. Each episode unpacks the stories, insights, and behind the scenes realities that shaped our experts' professional journeys. I'm your host, Lisa Gurdon, founder of Ellis Gurdon Consulting. In today's episode, we dive into the world of pediatric anxiety with Dr. Hanna Rue. As a clinical psychologist, behavior analyst, and leader in the field of ABA, Dr. Rue shares her take on how behavior analysts, clinicians, educators, and parents can transform the lives of children grappling with anxiety. This conversation is packed with valuable tools and perspectives to help you support your favorite young people along their journey toward emotional resilience. Hi, Hanna. Thank you so much for being here. Yeah, we have known each other for several years now, both as practicum supervisors as part of Northeastern University's Master's in ABA program. And that's been so fun talking and sharing how to do all the supervision and challenges, the ups and downs of it all.
Yes.
Definitely the ups and downs. And you have been so kind to do two continuing education presentations. One is part of a supervision panel, enhancing supervisory skills, a supervision panel for BCBAs that is in the on-demand library. We presented all together in Portugal at the International Applied Behavior Analysis Conference, and that was so much fun to have us together in
Yeah.
Lisbon and then have an audience full of people from all over the world doing behavior analysis, in all these different contexts. It was so cool, I thought.
Oh, yeah, it's one of those moments where you're pretty proud of what you do in the field that you're in. To have an international audience and to have folks from the US with us over there. I don't know, there's a special type of camaraderie, I think, that happens at those conferences, but the conversations are the same in terms of being interesting and valuable. Just the
Yes.
context is more exotic, if you will, than being in a conference center somewhere in the US.
Yes, but what I found so fascinating was like we're all behavior analysts, we're all
Yeah.
trained in the same way, yet we live, across the world from one another, and we are having those same conversations.
Right,
Right?
right.
Like that's so it may look a little different and have, but it was really cool. I loved that. And then you also did a presentation on pediatric anxiety, what every behavior analyst should know. And both those events are on demand right now. And at the end of the episode, I'll share a special discount for both CE events for those of you behavior analysts who would like to earn CEUs and those who are just interested to hear more of what Hanna has to say. So to start, Hanna, can you share your journey in ABA and talk about your clinical psychology experience and training and ABA and how the two kind of, mesh together for you?
I think at some point my story kind of converges with a lot of folks when you come into I sit mostly now in the world of autism and developmental disabilities. But when I started, I worked in an operant lab at McNeese State University with Dr. Cameron Melville. And so I was still wondering if I should go back. I was going back and forth between more clinical work, being a counselor, a psychologist, and then, stumbled upon this laboratory where they were doing animal models of human behavior, specifically sensitization and habituation. And I became extraordinarily interested in that. And so spent about 3 years of my life with 150 or so very large Sprague Dawley rats, I think they were. So my master's thesis was on the habituation theory of multiple schedule behavioral contrast. And I was really loving the EAB world and was very excited to dig into more learning phenomenon and things like that. We looked at things like addiction, alcohol addiction, cocaine. We looked at even eating disorders within that laboratory. So it was phenomenal. This is where my story kind of converges with others, though. It was back in the 90s, and a family had called the department to see if there was any graduate students who might be interested in working with their young child with autism. And my professor had said it would probably be a good idea to get some applied experience, even though I planned on at that point pursuing EAB for my graduate school career. And I went in to this family's home, and they had a 3-year-old, and he was just as cute as could be. But what was fascinating to me, all of the things that I saw us doing in the laboratory applied to this little guy, and that really stuck with me. So I continued, doing some work. That's when I worked on the front lines, 30 hours a week as a behavior tech, and took a few years off to do some consulting and moved to North Dakota. Uh, at that point, I was working for the state of North Dakota as a behavior analyst or a behavior psychologist. I forget what they called us. There weren't any behavior analysts at that time because there was no board. This is before the BACB, back in the dark ages. And so I was I worked with the state of North Dakota and the state of Minnesota, overseeing group homes for adults who were duly diagnosed with mental health issues and with developmental disabilities. So still working with some adults with autism, but across the gamut, just about everything that you can imagine within that world. At that point, I decided it'd probably be a good idea for me to get a clinical psych degree so that I could expand my breadth of knowledge and then also participate in diagnostics. So that's what I did. I went straight for a very traditional clinical psych degree at the University of North Dakota. That program is fantastic. It sets you up to be licensed, anywhere in the country. They set you up really nicely to be prepared for APA pre-doctoral internships. So I finished my PhD there, and I matched on match day with May Institute just outside of Boston, and that's when the focus really honed in on autism applied behavior analysis, working under Dr. Jim Lewiselli for a number of years. From there, then after about 10 years at May Institute, I ended up at Learn, where I'm the chief clinical officer, and I make use of both my applied behavior analytic degree as well as my clinical psych degree. I'm sure we can talk a little bit more about that. So it's a little bit of a winding road, but my heart is always within behavior analysis.
So when you think of that, and your varied experience, how did you integrate kind of that clinical psychology lens with the behavioral lens? Because there's overlap, yet there's different ways to conceptualize and describe behavioral phenomena, really.
Yeah, what's interesting and what I appreciate about my clinical psych background is the different theories of personality and behavior. And so having an understanding of, those other schools of psychology, I think only enriched my behavioral perspective so that I could translate, if you will. It's almost like speaking two languages. You can translate just about everything through a behavior analytic lens. And so just taking into account the environmental context, I find extraordinarily important, obviously, as a behavior analyst. And so with that, you know, and obviously, physiology plays some part in it too. And so we know, mental health, just like anything else, is going to be a combination of your environment, your genetics, your learning history, and things of that nature. So I can understand, some of the, overt behaviors that we see and measure, as well as some of the things that people talk about within the skin, if you will, those private events. And so, for example, I've worked with folks who have more like an obsessive compulsive disorder, and they're talking about intrusive thoughts that they have. And so that's where I think some of my clinical psychology training comes in. I don't shy away from talking about those things, but I can understand their impact as well as provide appropriate treatment, taking into account, that behavior analytic component, looking at the environment and how that environment, how the individual's environment may impact, what they're experiencing privately.
Yes, absolutely. And so that brings us really to, your focus on pediatric anxiety, and really integrating those two approaches. And I love that because it really adds so much richness to our understanding of our kiddos. And it just seems like everyone is walking around with a level of anxiety that we've never seen. There are way more kids who are diagnosed with anxiety and other complex disorders when at younger ages, and it's manifesting in all kinds of challenges. Um, what what do you think is happening right now, like from your perspective?
Mm. That's a complex question with a
Yes.
probably even more complex answer, right? I think there's a lot happening. And where I sit, we serve mostly individuals with autism, but what we're seeing more of um, are children coming in with additional diagnoses of ADHD,
Mhm.
anxiety, and depression. And I think probably just like with autism, we're getting more awareness around anxiety and diagnosing it better. Pediatricians are probably more aware of those types of mental health disorders now, and providing appropriate referrals. Everyone's probably seen on social media and within the news that we're in a mental health crisis nowadays. There's probably some impact of social media,
Mhm.
right? Um, and the pressures on young folks these days are different, than what we experienced and what I experienced whenever I was young. And so I can't imagine having access to information 24/7, constant contact, and things of that nature. So I do think there's a component there. Um, I also think there's a lot going on in the world too. Um, and when you think about stressed adults, right,
Yes.
in a household with children, that certainly has to have an impact as well. So I think there's a number of environmental factors, but we're maybe as a society, as professionals, getting better at identifying those things and diagnosing those things now, just like we're better at identifying autism and diagnosing that.
Yes, I agree. And it feels like there's a little bit more of a willingness to go to that
Hmm.
mental health diagnosis than there was before, where there's such a stigma, right, for decades about that mental health diagnosis, and no one wanted to acknowledge it. And it seems like people are shifting into the space of, okay, here we are, here's what we got, now what do we do about it? And behavior analysts have traditionally, shied away from those mental health diagnoses, right? And you talked about how your clinical psychology training allows you to move toward it, right? To say, to embrace it and say, okay, here we go. This is what we have. This is how, it's working. Um, for those behavior analysts who are out there listening, what are the paradigms that we can use to help us, you know, understand anxiety and develop more skills and confidence to say, okay, I got this. We're gonna deal with this.
Hmm. Well, really, behavior analysts have everything that they need in terms of understanding, right? This is an overt behavior. And a lot of times it's around a learning history of avoidance, right?
Right.
You contact some aversive stimuli, situation, person, whatever it might be, and there's a response. And then if it's repeated or if it's just that one trial learning, sometimes once is enough. And you're like, I'm going to avoid this as much as I possibly can. And that's, again, a relatively simplistic perspective of it. But it really, I think, kind of captures it. What you hear from individuals who are experiencing anxiety is they're oftentimes trying to avoid or try to get away from something, right? So if we can imagine what that is in a complex environment, it might not be so easy to suss out exactly what that is, or what anxiety looks like when you're first getting to know an individual, right? Because you can have avoidance that's manifested, vocal verbally, like I don't want to, that's not okay. You can have someone pull away. You can have someone just not respond, right? And so avoidance behavior, as good behavior analysts know, comes in many forms and fashions. Um, and so when do we come to the idea that it's, anxiety? I think that's a little bit of a more complex. kind of question too, and that's when you start to collaborate with other professionals, right? So that maybe it's not, um, if you're finding that what your work with this individual is not producing the results that you would expect, you're not getting as far along as you would expect, and it's more, um, you're seeing it in, kind of generalized across environments, right? The avoidance behavior is happening across multiple environments with multiple folks. You probably want to, bring someone else in. But it really is, it's about avoidance and escape, and aversiveness that just make you uncomfortable.
Yeah, and I think there's that, avoidance and escape from those external events that make you uncomfortable, but also internally. So, right. So
Oh,
if
yeah,
you're right, if you're having, a big dramatic, meltdown and you're getting a lot of attention and avoidance and escape and there's a whole thing, now you can ignore kind of that feeling. And I don't think that we necessarily at this point, any of us really, or a lot of us, struggle with the tolerance for that, right? And kids don't know what that is. It's scary, it's and so I think that's a big part of it too. It's that internal space that's
yep,
uncomfortable, and we as behavior analysts can't see that. So
nope,
I mean, I think we have to look at those, overt anchors, those behaviors you can see to indicate what might be going on internally, as well as that verbal behavior, that verbal report, that self-report that people can say when they can. And you work with
right,
you work with nonverbal individuals who cannot say that. So we
right.
need, right, to be very in tuned to both those private events and the behaviors we can see.
And that's what, I love about clinical psychology. Whenever I work with young folks experiencing anxiety, one of the first steps that we take in treatment is what we call psychoeducation, right? And
Right.
it addresses those internal experiences. And a lot of times that's what you were just saying. Some kids are responding to that too, like my tummy hurts,
Yes.
my head is hurting, I'm getting dizzy, I feel my heartbeat, really
Yes.
fast. It's hard to swallow. So it's all of these physical manifestations. We might
Yes.
not be able to see that, like what you were talking about. So one of the first steps that we take is, yeah, you're probably experiencing this, and let me give you some labels for that, so that you can now start telling people, this is what I'm feeling. And for a lot of kids, that's really helpful. And so there's a number of books that you can find on Amazon or in bookstores that talk about, in very simple, plain language, those experiences, right? And sometimes just telling kids that this is normal, this is your heartbeat
Yes.
fast because you're scared or you're worried or something like that. Sometimes that can help, um, an incredible amount, just so kids know that it's normal, right? And it's not, their body's about to explode. So I've even seen the initial psychoeducational step
Yes.
have a big impact on kids, because you're right, those private events um, can be really upsetting.
Yes, yes. And it's also a psychoeducation for adults too,
Yeah.
to say, yeah, this is happening. It's okay, right? We all experience anxiety, and kind of normalizing it for the adults in their lives as well. And to have
Yeah.
some, some compassion for it like that, and understanding like that's what may be happening right now. And that doesn't
Right.
feel very good. And we've
Right.
all been there.
And yeah, we've all been there. At some point in your life, you're going to have that anxious response where you
Right.
have, the increase in heart rate and you get a little sweaty and whatnot. But I think you're right too. Especially, we've had generations in the past who weren't so open about talking about these things. So I think about maybe nowadays, maybe some grandparents and things like that, and educating family members around that. Like when you see the little one or the individual in your life who's, kind of getting quiet, maybe putting their head down or whatnot, those can be indicators of anxiety, and maybe they just hadn't recognized it, right?
Right.
And so someone's not talking or not responding in a way that they should be, given the context or the social environment. Sometimes that psychoeducation can also help family members understand that someone's in distress.
Yes, yes. And similarly, I think it's important to educate teachers and school teams as well, who may not have that level of understanding, especially I think in behavioral, more agencies and behavioral programs that are really strongly rooted in ABA. Sometimes that approach isn't, or that level of understanding, the private events isn't quite talked about as much as it should. And so I think we all kind of need to level up a little bit and kind of like go there. Like, let's all go
Yep.
there. And I don't know, for me, collaboration has been the heart of how I've learned so much about anxiety and how I've learned how to address it, and support people with anxiety. Can you talk a little bit about that collaborative piece in your work?
That's what I get really excited about, especially when I was working with a few anxious adolescents at May Institute. It was an opportunity to teach about how to generalize some of these skills and work on things. And so, just like you collaborate with a speech language pathologist, with a medical professional regarding, medication or something of that nature, a psychologist can provide some of the same support. But what's really cool is if you're working with a behaviorally oriented psychologist and they're doing cognitive behavior therapy, CBT, the B is behavior, and most of the times the B is applied behavior analysis. And so you can take that piece of it and work with the clinical psychologist to participate in exercises, help, diaphragmatic breathing exercises. You can work on, using the subjective units of distress SUDS scales, so 1, I'm feeling really calm, 10, I'm, really, really anxious, and things of those nature. You can also work with the clinical psychologist to help, identify those ABCs, right? So as clinical psychologists, we're oftentimes kind of trapped, if you will, in our office setting doing 50-minute sessions. And if I have a behavior analyst come in and, show me some graphs or show me some ABC data about where an individual is experiencing some of these distressing experiences, it's really very helpful for me in our treatment path. And so I can collaborate with that person about what tools to use, practice with them in the within the office setting or even remotely. So there's lots of opportunities for collaboration and learning on both sides, right? um,
Yes.
that's what I really enjoy, and I've really enjoyed working with behavior analysts in that context to work on pediatric anxiety.
Yes, absolutely. And I think it's so important that all of us as professionals are curious, right? We go into those collaborative meetings ready to ask questions. Oh, tell me more about that, right?
Right.
I remember early in my career when I was working with social workers and in the school context, I remember going into their offices and sitting down and saying, "Okay, I don't understand what you're talking about when you talk about CBT or this or that or the other. Tell me. Like, tell me about it. Tell me why. Tell me how it works, and tell me how I can support you."
Yep.
And that's how I learned, by just asking, saying, "Tell me more," and why,
Mhm.
and I want to learn. And that, I mean, has been so valuable.
It's incredible, and that's really the scholarly part of our science, right? Is that we should always be
Yes.
clinically curious throughout our journey, and regardless of the field. Anything, you know, behavior encompasses just about everything, and so there's so
Yes.
much to learn. The learning never ends, and so that's what I've always appreciated. And then also, that individual. And so if you have a client, and again, I've been on both sides of it. So if you're a behavior analyst working closely with a family in home or with this client, you probably know that person better than I do, doing
Yes.
50-minute sessions, right?
Right.
So I've got a lot to learn from you, just from your experience with that client and with that family.
Yeah.
So let me learn about, what is that context really? What are you seeing there?
Yes.
And so it can really make for a richer, uh, treatment collaboration for that individual.
Yes, absolutely. And I mean, I've worked with clinicians who have, taken. I say, okay, you take that.
Yeah.
I can't really touch that piece of it. So you take that, I'll
Right.
take this. I'll support,
Right.
parents and understanding that, and, in the context of parent coaching and how to follow
Yes.
up, right? And I love that, right?
Yes.
And that's just such a rich experience. I really enjoy that. And I always tell, I'm sure you do also, talk to our students, our graduate students, about collaboration. I feel like, I'm always talking about it, and hey, have you had a
Hmm.
chance to, here's where you would want to connect with so and so, and you got to start your career, I think, with that perspective, with that openness.
There's something to be said about being humble, right? So a humble behavior
Yes.
analyst, but that can be applied to a humble psychologist, a humble,
Yes.
medical practitioner, physician, if you will. And so I do talk about that a lot. I think, way back in the day, there were some behavior analysts who thought, we could do it all.
Yes.
Um, and maybe that, helped to develop a not so great relationship with folks that were out there. I remember again back in the 90s,
Yeah.
having a hard time explaining to folks, and then also having some folks in my life who were pretty adamant that we could fix just about everything and we didn't need anyone else.
Hmm.
When in fact, that is absolutely not true. Um, Even within behavior analysis, there applied behavior analysis, there are those specialties. And so there are folks, for example, who are trained, very well trained in acceptance and commitment therapy,
Hmm.
ACT, right? ACT. And so, just because we have that within our field doesn't mean that everyone can be doing that, without the appropriate training and supervision or whatnot. So if you don't have that training and supervision, even collaborating and learning within our field about that, specific area, as well as outside of the field from a psychologist or a social worker or pediatrician. It is all about collaboration because there is evidence-based interventions
Yes.
in each one of those helping professions.
Yes. And I think when you are talking with a professional trained in a different discipline, um, we, all of us, in behavior analysis and other disciplines who are differently trained, I think there's that translation process, right? That we can do
Hmm.
in our heads of like, okay, they're talking about, okay, I can explain that with respondent and operant conditioning.
Yep.
Okay, I can use relational frame theory,
Yeah.
right? Oh, I think, and kind of translating that in your head so you can understand it in the way you were trained, but you're really talking about the same the same thing when it comes down to it, the challenges, the supports that need to be implemented for that individual to be successful in their life.
Yeah, a lot of it is semantics. It's pretty
It
funny.
really
Just like
is.
you walk into an SLP's office and you're doing the exact same thing and calling it two different things, and it
Yes.
really is semantics. And who the heck knows what a tact or a man? We
I
have some
mean,
pretty funky things in our world too, right? So, requesting and naming and things of that nature. Yeah, there's something to be said speaking a common language, just
yes.
understanding it from a behavioral perspective.
Yes, I remember in graduate school reading a study, um, or it wasn't really a study. It was an article about why behavior analysts should study emotion, and it's an
Mhm.
old article at this point. I'm sure you know it, and I was enthralled because in graduate school I was also in the late '90s as well, and
Yep.
no one was talking about that, and I was like, there's got to be more, and there's got to be a place for it, and they just say, yeah, we all need to have this common language. We all need to use the term anxiety. That's
Mhm.
how we can start having these conversations. And yes, behavior analysts should learn about
Mhm.
emotions, should look at it, should talk about it. And I was like, yes. And we're getting there. It's taking some decades, but we
Yeah.
slowly but surely, we are getting
Yeah. No, I've
there.
seen tremendous what's happened in the past, 30 years.
Right? It's fascinating.
Yeah.
It's definitely an evolution, and an evolution we can learn from as we move
Yeah.
forward.
Yeah.
Um, so Let's move on from the sort of understanding and the paradigms for a moment, collaboration, talk about strategies, right? Because when it comes
Mhm.
down to it, we really want to help people learn how to manage anxiety. We can't delete it forever. We can't
Right.
get rid of it. Anxiety is part of life. It helps us survive. It helps us do well. And so we all have to learn to live with a certain level of anxiety, tolerate the discomfort and all of that. What have you found to be, just some of the best strategies that you found to support really the people that you've worked with, those people diagnosed with multiple
Mhm.
um, diagnoses, autism, anxiety, and ADHD, all of those. And we're seeing, I'm sure in your career too, you're seeing way more people with complex diagnoses. It's with multiple diagnoses. It's not a one stop kind of a one
Oh, yeah.
diagnosis situation anymore.
Yeah. No, that's what yeah, I think I'm seeing it more and more now than ever before. The school age individuals
Yeah.
coming in with autism and, a co-occurring anxiety disorder. In terms of, you know, the evidence-based interventions, starting out really simply, when you're collaborating with, if you're looking at pediatric anxiety, collaborating with your social worker, a counselor, or clinical psychologist, that psychoeducation piece, like I said,
Yes.
is really important. I've used a number of different books that I've, taken from Amazon. Psychoeducation doesn't happen just in that one, 50-minute session. Kids need to get this information, from different people at different places at different times, right? Because
Yes.
they have to be reminded, reassured. We have to ensure that they can talk fluently about their heartbeat, about their stomach or whatnot. And I see a lot of kids check in. Yeah, my heart, is beating fast. Right. Remember, we talked about that. And so that psychoeducation piece is something that we can all do. The one thing that I say is make sure that we're all using the same language, right?
Mhm.
And so if you talk about your heart racing, right, is different than your heart beating. So, again, make sure that the language, your tummy feels weird or your stomach feels nauseous, however you want to do it, make sure that those labels make sense to that young person. And that's the language that the family's going to use. So I would continue with that psychoeducation until, the labels are there. They can, fluently talk about what they're experiencing inside and kind of use some of that language. And then in terms of actual tools, like I said, the identification using the some sort of units of distress, like I said, is a really nice way to communicate that very simply. So if you need to engage in a certain practice or maybe even remove yourself from a situation, having a thermometer, or what
Mm.
have I used for? I think some sort of bathtub with the water filled up or something. The scale can be whatever that the child wants it to be. And so usually collaborating again with the counselor, what is this going to look like? Practicing that. Again, it takes a little while to become fluent on what those things mean. And again, it's subjective. So you want
Right.
some practice around, what's this child look like at a one versus, another child at a one
Yes.
versus a five versus a 10.
Yes.
Um, so you have to get to understand that and define it. And it doesn't happen in one clinic, in one setting. You refine that over time. And then what are the antecedent interventions, for example? Like, how do you prime someone? Again, what's the language that you want to use? How far in advance do we talk about these things? That's important because anxiety
Yes.
happens when that trigger is coming up. Do I talk about, we're leaving for the trip in 3 days, or do I talk about it within 24 hours, right?
Right.
So knowing about when to implement antecedent interventions and again, the language to use, and then the consequence strategies too, right? Like, when do we leave a context, right? When do we, call in for supports and just, you know, when do we need to get out of there? Other things I like talking about are diaphragmatic breathing.
Mm.
So I've seen in a million different behavior intervention plans, let's breathe, let's take a breathing break. And then I just watch a kid sit there go,
Right.
and I'm like, and then
Yes, the breathing. Yes.
yeah, the breathing, I'm like, it doesn't, it doesn't necessarily work for everyone. And first you have to do it with fidelity. You've got to do it correctly, right? And so I'm really big on talking about what that is, belly breathing, and how to practice it. You have to first learn to do it correctly to be able to use it. And so you
Yes.
can't tell a kid to breathe and expect them to experience calm or whatnot. So I think sometimes that's something that gets a little confused out there in the behavior analytic world.
And it's the same for adults. Like we all need
Right.
to, we have apps that tell us to breathe for God's sakes. Like,
Right.
we have to breathe and do all those things so we can stay calm. And then we model that and we talk about it, right? And I think that's something, there's a lot of universality to what we're talking about here,
Oh
for
yeah.
all humans. Like this is not a kid problem, right? This is a
Oh right. Right.
all of us need to work on those skills.
Well, and you'll see me sometimes, depending on the context or, where I'm going or whatnot. I still use I went through a systematic desensitization. I used to have an extraordinary fear of flying.
Oh my
Absolutely.
gosh, that would not
Like,
be good with your current job. And when I see Hannah, I say, "Where in the world is Hanna Rue?"
yeah, I'm traveling about 100 days out of the year. I, take probably 100 flights or whatever.
Yes.
And so it used to be debilitating. And so
Uh,
it was actually Dr. Cam Melville who said, okay, well, let's do systematic desensitization. So before I even went into clinical psychology, and I went through and I did a hierarchy or whatnot. And that's when I learned about, appropriate diaphragmatic breathing. And so I still use that. And obviously,
yes.
flying now has become a lot easier, but every once in a while, you hit a few bumps and I'm just like, and instead of bracing up, I put my hand on my chest and a hand on my belly, and then I sit there and I have to think about it, right? To engage those muscles, to engage, the full
Yes.
breathing exercise. And so I still use it. And it's been very effective. But again, it's a skill that you've got to
Yes.
develop and practice and
You
ensure that you're
practice.
doing it. Hmm.
Yes, and that practice. And I found also kind of visuals to cue kids can be helpful, especially if
Oh,
they don't
yeah.
have the language to
Yep.
process
Yep.
that verbal language. Visuals I found to be very helpful. Also, I found to be very helpful not talking very much as
Yes.
adults, like keeping
Yes.
the verbals down, because if you're anxious and stressed, you cannot process language. And so everyone just needs to like, bring it down.
Yep.
And adults have to practice that. And I keep going back to that because kids can't learn if adults around them don't do it and show them and support them. So it's a
Look,
big part of the puzzle.
yeah, and it's really scary to watch a kid have a panic attack. It's really scary to
It's
watch
scary.
anyone have a panic attack, but when you watch a child
Yes.
have a true panic attack, it's
Yes.
very, very scary. And so you do have to learn to remain calm and to understand it's just a panic attack. They are, hyperventilating. They're frozen oftentimes. They're
Yes.
crying. They're really distressed. And like you said, to remain calm.
Yes.
And a lot of times, and what I've done, is to try and get some sort of like focus, right? Like, look at me, look at my
Yes.
eyes, just try to get their attention and some repeated phrases, right? And again, these are things that you talk about beforehand.
Right.
For experiencing the attack, I'm probably going to hold your hands and I'm going to say, look at me,
Yes.
look at me, those sorts of things. And then with some individuals, I'll say, we'll start talking about breathing and we'll wait for a moment. But again, it's kind of learning that pace with that individual child
Yes.
when in that crisis situation, and talking about, previously what will happen when these
Yes.
very distressing situations happen. But you're right.
Yeah.
You've got to remain calm in a very distressing situation.
Yes.
And you've got to remain quiet most of the time, which is hard for some people.
It's so hard because we tend to keep talking. So I work with staff a lot on that. Like we
Yeah.
want to keep talking, you have to do the opposite. And
Yeah.
so replace it with some breathing, right?
Yeah.
And having your own mantra, right, during
Yeah.
that time. And learn to kind of I learned I had a child who had panic attacks during a period of time. And I had to learn to ride the wave, to not
Yep.
try to control it, not trying to stop it, but to
Yep.
ride that wave. And I had to learn and I had to practice.
Yep. Yep.
And it took a minute, but we did
Mhm.
it. And the panic attacks went away. And now I know what to do in those situations. But I called my psychologist friend and said, "Hey, I have no idea what to do. Um,
Mhm.
what tell me." And she said,
Mhm.
"You have to ride the wave." And she told me exactly, what you described and what I need to do. And then I was like, I had a plan.
Right.
I
It's a
have a
behavior.
plan. Yeah. I was
Yeah.
like, okay. I may call you again because I don't exactly know how this is going to play out, right? And I may need some support, but I have a plan now, and it worked. And it's we have it so much to learn from one another. And when I think about young behavior analysts or new behavior analysts in the field, aspiring behavior analysts, our students that we have, Hannah, what advice would you give them? After decades in the field, and when they do have that first client, the second client, whatever, who is diagnosed, with anxiety, what advice would you give them? And I guess would that be, maybe that's the same advice you'd give to your younger behavior analyst self, about it.
Yeah. Well, my younger behavior analyst self would be, um, you don't know everything.
Yes.
You need other people. But, when I'm talking to our graduate students, recognizing that it's okay to ask for help and that
Yes.
it's okay to not know. So one of the things that I have at Learn Behavioral is a peer review system. And so actually we changed it to a clinical skill building rounds,
Hmm.
and we've kind of
I like that.
rebranded so that the focus is we're helping you build skills. We're
Yeah.
building our skills. You're building your skills. And that's what it's all about. In the
Yes.
beginning, you're not going to know everything. You're just starting out, right?
Yes.
And every client is different, presents differently. Anxiety, if you will, manifests or looks different. And so it's okay to reach out, to find supervision, to ask questions. Like you said, always be clinically curious,
Yes.
mm, and and to collaborate. Right, that's where you're going to learn a lot. Like what you were saying, talking to social workers, talking with psychologists. I've learned so much from the collaborations over decades. But I think some people have that feeling that they should know more,
Yes.
right? I think there's a lot of
Yes.
expectation on folks, and folks hold themselves to a standard, uh, and you don't have to. There's a bunch of us like you and I are always available to our students. Supervisors or should be available, to the younger, newer behavior analysts.
Yes.
Uh, and so it's okay to reach out, and it's okay to ask for help. And if you recognize that something is outside of your scope, to speak up.
Yes.
Um, ethically, we're obligated ethically to speak up and to refer clients to, folks who might have experience with, whatever it might be, if you can't access that supervision that you need in order to appropriately treat. Um,
Yes, and I think we need to be comfortable and practice being in that space of I don't know and I'm going to find out versus I don't know and I'm not going to deal with it.
right.
And those are two different things. And so ethically, we need to look at those barriers, right, to progress, and barriers to implementing interventions, and we need to deal with them. And so
Yeah.
that means asking for help. That means saying, I'm not quite sure. I see this problem. I understand it this way. I'm not quite sure what to do about it. We need some people to
Yeah.
help us, right? And that's the skill set I think that we all need to always work on. And like
Mhm.
it's okay, and tell ourselves that's okay, like that's all right.
Oh, absolutely. Right. If you're within your first year out, there is no expectation. If you came from a, early intervention place, with like little 2 and 3 year old toddlers, that's a whole different thing than, first or second grade in a school environment, as right? It's different. And so asking for help is the appropriate thing to do, and recognizing, when it's outside of
Yes.
your scope, it's always okay. And if someone tells you it isn't, then that person probably isn't practicing
Right.
ethically. Sometimes that does happen too.
Right. And it's not only your first few years out, it's always. I mean, I'm calling people. We've had conversations of like, do you
Right.
know all the whole task list, Lisa? I have to ask Hannah, and you're like, no, I look stuff up. I model how to find it, right? And say, I don't know, right? And so we can't know everything. And we just have to be humble and ask those questions, find those people who know more of the answers and go there because it
Yeah.
will be a very enlightening and fulfilling experience to go there.
Yeah. I and with the skill building rounds that we do, we say it could be anything. It can be, I'm not sure how to program for the next step. I'm not sure how to explain this to the family. The response, the client's response doesn't is they aren't responding in the way that I thought they should. It could be, any one of those things. It doesn't matter.
Yes.
We welcome that. Again, it's about being a scholar. It's about engaging in scholarship and learning.
Yes.
Um, and that's how we should live our lives. Because yeah, I learn every single day too, Lisa.
Right. Right. I mean that's the whole sort of, my why for the continuing education program and my why, for the podcast is talking about these things that are hard, and sharing what we've learned, and sharing our vulnerabilities. Yeah, like we don't know
Yeah.
everything. And so that's, yeah, for me, what it's all about too. And I am just so thrilled that you spent this time with me, Hannah. It's always nice to connect with you and to talk about these really important things. So thank you so much for being here.
Well, Lisa, you know how much I appreciate your dissemination of information and your support of behavior analysts, around you, and that you're able to to touch outside of even New England or whatnot. So I appreciate that. I think you're one of those leaders that truly believes in dissemination and supporting others. And so I'm always happy to join you and be able to your world.
Thank you, Hannah. Thank you. Well, this has been Behind the ABA Talk podcast. I'm Lisa Gurdon, and we have had our amazing guest, Dr. Hanna Rue, here, who is at Learn Behavioral, leader in the field, traveling all over the world talking about behavior analysis and how to practice ethically, and how to experience joy while doing that. So I appreciate all that you do, and thank you so much for sharing your journey and your recommendations for deepening our understanding of anxiety of our young people, the people we support and their families, so we can help our clients, our families, the individuals we support, the individuals in our life experience really more meaning and joy, because I think that's what it's all about. So be sure to click the link in the podcast episode description to listen to Dr. Rue's on-demand CE in the Ellis Gurdon Consulting Continuing Education Program hosted by Behavior Live. And her CE is Pediatric Anxiety, what every behavior analyst should know. Hanna Rue is also one of the panelists on Enhancing Supervisory Skills, a supervision panel for BCBAs, where behavior analysts can earn CEUs, supervision CEUs. And then the promo code is HR Podcast, HRPODCAST, for 50% off of both CEU events. So I hope you go to the events and hear more from Hannah. And thank you again for being here. And a special thank you to my podcast producer, Cole Asher Hoffman. And we will see you next time.